The good thing about my talk is that it's not as controversial as everything else seems to be. Should we get braces? Should we do surgery? Mine, everyone has to breathe. So it's not really there's nothing we can argue about that. But the other good part about my talk is that I don't ever mind talking about something that is so complicated and sometimes so devastating, and then actually stand up here and say, you don't have to worry about it because it does not apply to the majority of you. So one thing that is very important is that we need to understand that pulmonary issues are not a huge hallmark of CMT. Some patients are affected a lot more than others. Some patients are affected very mildly with breathing problems, but for the vast majority, there's a lot of other neuromuscular diseases that have severe breathing problems, not Charcot-Marie-Tooth disease. I am not a neurologist, so I'm not going to pretend to be one. Other neurologists have already discussed this much more eloquently than I have, but it's a spectrum of disorders, as everyone knows, CMT1, CMT X-linked, 2, and so on. But basically, it affects the peripheral nerves that carry motor and sensory information to and from the brain. No, I'm having problems. Oh, there we go. Usually, the motor symptoms predominate, and usually in the lower extremities first, and then the upper extremities next. And also, there could be sensory problems, again, in the lower extremities and then the upper extremities. This is just a very basic overview from a non-neurologist point of view. However, where my role comes in is similar to other nerves. The phrenic nerve, which I'll talk about in a second, as well as other nerves that affect breathing, may also be affected. And what happens is, just like you get peripheral nerve dysfunction in the legs and the hands, you can also get it with the breathing muscles. And again, I want to point out that this is not very common in CMT. So what are the main pulmonary problems? There are three things, really: diaphragm dysfunction, vocal cord paralysis, extremely rare, and then the most common is sleep disorders. I borrowed this slide from the medical art library, but basically it's a very simple diagram to show you what I'm talking about. You have two diaphragms, one on the right and one on the left, and you have two phrenic nerves that run from the spinal cord down middle of your chest on each side, and they innervate and help control the diaphragm. So to breathing, obviously the lungs are very important, but really the chest cavity is the most important part of breathing. What happens is, inside your chest cavity, it's a vacuum. And we somehow have to use our chest wall. When we take a deep breath in, our chest wall moves out, our diaphragm moves down, and that opens up this cavity, and the lungs will open up inside this cavity, and that will allow us to breathe. As I mentioned, there are nerves that affect the muscles between the ribs, which pull out the chest wall, and there are muscles that affect the diaphragm, which pull down the diaphragm. We believe that the diaphragm probably plays the most important role in breathing. And as I explained, it runs down. There are two diaphragms, one on the right and one on the left, and the phrenic nerves that run down the center of the chest are the ones that innervate the diaphragm. So what are some very early signs of breathing problems? Now, again, this may apply to other neuromuscular diseases a little bit more than CMT, but one of the earlier signs that I get that when we have our CMT clinic at Cedars or other neuromuscular clinics at Cedars, I ask the patient, do you have trouble breathing? And they say, no, I'm fine. I walk fine. I'm not short of breath. And then I say, okay, well, how do you sleep at night? They're like, well, I sleep on 3 or 4 pillows and I'm propped up a little bit. And I say, why? And they're like, well, I don't know. It makes me feel better. Well, what it is really, the problem is that as your diaphragms get weaker, and very early signs of your diaphragm getting weaker, when you lay flat, your diaphragm cannot move as well as if you're sitting up. So a lot of these patients tend to become more and more inclined when they're sleeping because it's more comfortable for them, and they don't know that it's actually because they're having problems with their breathing. So how do we test these patients? Again, when I was asked to give a talk on CMT and breathing, because it's not as common a problem as other things, what I did is I asked a lot of patients and I asked a lot of people, what are the biggest questions that they have? What are the biggest questions that CMT patients have about their breathing? And I'm trying to answer as much of them as I can here. So how do you diagnose breathing problems in patients? The simplest test that we do is what's called a pulmonary function test. You come in, you sit in a little glass, I don't know if anyone's ever had it, a little glass booth, and they ask you to breathe in as hard as you can, breathe out as hard as you can, breathe in as long as you can, and it's about a 30-minute test. This gives us many parameters of your breathing and of your lungs. It helps, it tells us how well your lungs can function. It tells us how much air the lungs can have, how much air the lungs are releasing. It also tells us how well the air that goes into your lungs is being oxygenated by the blood. So it's kind of a complex test. Although it's simple to do, it's a complex test that is not always needed for every single patient. So what I always say is, do you need full pulmonary function testing? Probably not. If you have any symptoms of any early symptoms of breathing problems, then I say yes, we do a baseline pulmonary function test. After that, we do what's called just spirometry, where we have the patient breathe out as hard as they can, and then also have the patient inhale as quickly and as hard as they can. And we do this in the clinic. And we usually do this for most neuromuscular diseases every single time they come to our clinic at Cedars. For CMT, we do it at least 2, maybe 3 times a year, where we just follow these numbers. And the 2 numbers really that everyone feels are important are what's called a forced vital capacity, which is we ask you to breathe out as hard as and quickly as you can. And then what's called the NIF, a negative inspiratory force, where we have you breathe in against the closed valve and to see how much force you can breathe in with. We don't know, over the years, we said which one is better in telling us muscle weakness and diaphragm weakness. We don't know if a long time ago it was believed, originally it was believed that the negative inspiratory force was a better marker. Then later on it was believed that the forced vital capacity was a better marker. Now we kind of use both of them, and we test both of them every time you're in clinic, or at least 2 to 3 times a year. And that helps, I think the 2 combined help gauge early muscle weakness in the breathing, in the breathing muscles. That is probably the simplest test. There are other tests to look for diaphragm movement and diaphragm function. They're a little bit more invasive. This one is called what's called the sniff test. We have you stand in front of pretty much like an X-ray, and we have you breathe in and out. And we shoot, an image of your chest, and we watch the diaphragm move up and down. And if you have early diaphragm weakness, the diaphragm does not move as well. And then if you have more severe diaphragm weakness, then the diaphragm doesn't move at all. And we can see that on this test. So it's also not very invasive, but there is some exposure to radiation. The final test that we can do, and when I was here earlier and listening to the talk about phrenic nerve or about nerve conduction, everyone obviously hated that, and that you guys don't enjoy that too much. Well, we can also do it for the phrenic nerve. We stimulate the neck and see how well the phrenic nerve functions. Most patients, as you would know, don't really like that, that's obviously a little bit more invasive. And then the most invasive, in my opinion, is what's called a diaphragm EMG, where we put, just like they put needles in your legs or in your arm muscles, we can put needles in the actual diaphragm itself. That's a little bit more complicated. I don't recommend that every neurologist do this, but you should definitely go to a neurologist that knows how to do this if needed. So how do we manage this? The management, I think, is the biggest topic, and mostly because this all applies to sleep apnea as well. And sleep apnea is much more common, and we're going to talk about that towards the end of the talk. Anyone that knows anyone with sleep apnea, or if you have sleep apnea, you wear what's called a CPAP machine. You have a little device next to your bed, and you wear a mask when you're sleeping. In neuromuscular patients, and there's a caveat to CMT patients, which I'll talk about in a second. But in general, in neuromuscular patients, we do not recommend CPAP therapy. CPAP therapy is just what's called continuous positive airway pressure. This is used in just about every single sleep apnea patient. With neuromuscular patients, and I'll explain why later, we recommend something a little bit more sophisticated than just a simple CPAP. There's something called the BiPAP, which is bi-level positive airway pressure, or even newer forms of non-invasive ventilation. And if anyone has ever seen anyone in the intensive care unit or on TV where they have a tube in their throat hooked up to a breathing machine, these more sophisticated devices are that ventilator in the ICU condensed into a smaller machine at home and used non-invasively. The beauty of this is that it's much more friendly. The patients are much more compliant, and it's much more comfortable for the patient with these types of devices. We can control more things, more parameters on it, and it helps the patient much more than a simple CPAP. We'll talk about this in a second, sorry. So this is a simple CPAP machine. There's two of the more sophisticated devices, what's called an Astral here and a Trilogy here. And those are the only two that are really out there right now. And these are the mini ventilators that we can have at home and use non-invasively through a mask. And everyone that has sleep apnea knows and hates the masks that you wear. The main one is the one that makes you look like Darth Vader. But just know that there's many masks, and if you do have a CPAP machine, please ask your DME company to show you other masks, because usually they give you one of these or one of these big ones and leave it at that. But just know that there's a lot of masks that are much more comfortable, much better to wear at night. And honestly, they come out every couple of months with a new mask. I think this is probably the latest one, which just covers up a little bit of your nose, and it's very comfortable. In fact, I was in clinic just this past Wednesday, and I had a patient that hates the mask, hates every type of mask. So I had the DME company come in and say, I was asking him, I'm like, is there any way we can adjust one of these masks, make it more comfortable? And he literally said, oh, well, here's a brand new mask that just came out on Monday. And, it was just approved and it's being sold since Monday. And literally every couple of months, some kind of mask comes out. So always ask if you're not comfortable with the mask that you're wearing. A few key points that I'd like to point out. With CMT, as well as with other neuromuscular diseases, the problem is not your lung. And that's important. Now, of course, CMT patients, just like anyone else, can smoke and can have other lung problems and can end up with emphysema. But for the most part, in neuromuscular patients, the problem is not with the lung, which means that your oxygen level is not the problem. Okay, the problem is with your chest wall and opening up your chest cavity. So when we breathe, and this may be too simple for everyone, but when we breathe, basically, in a nutshell, we inhale, we take in oxygen, and we breathe out carbon dioxide. Anything that prevents one of those causes problems. In lung problems, you can't exchange oxygen very well. In respiratory muscle problems, you can't release the carbon dioxide very well. Therefore, what happens is, it was mentioned earlier, you go to a doctor, an orthopedic surgeon, and you say, do you know what CMT is? And they're like, well, yeah, they pretend to know what it is, but really there aren't that many orthopedic surgeons that deal specifically with CMT. We're fortunate to have an excellent one at Cedars, but if you go to many other hospitals, they don't have anyone that specializes in CMT. Well, that is multiplied 1,000,000 times when it comes to pulmonary. I think there's a handful of us in the nation that deal with neuromuscular disease and with CMT. So what happens is you're going to go to a pulmonologist in the community and you say, I have trouble breathing. The first thing they're going to do is they're going to give you a bunch of inhalers, because that's what, anyone that has problems breathing has to have asthma. So they give you a bunch of inhalers, and that doesn't work. Then you go back and say, well, that didn't really help me very much. Then they say, oh, well, you know what? You probably need oxygen. So they give you oxygen to wear, and that does absolutely nothing for you. So that's something that's very important. The hallmark of treatment of any breathing problems in neuromuscular patients is non-invasive ventilation, is the BiPAP, the Trilogy, the Astral, not really oxygen. And the reason I put this in here is because you would be surprised at how many emails or questions I've gotten from CMT patients out there that say, I've been on oxygen for a couple of years now and it hasn't helped me. Why am I on oxygen? And the answer is you don't need to be. And then, of course, now this doesn't really apply to too many adults with CMT. It's more in some of the children with more severe forms of CMT that have complete respiratory failure. They can have, if after the non-invasive ventilator doesn't work, then we can do what's called a tracheostomy in these patients and hook them up to the same device, the same Trilogy device as a ventilator at home. And this is what a tracheostomy looks like. It's a little hole that we put in the neck, and the machine will actually breathe for them. Now, again, this is unbelievably rare in this patient population. So the last thing that I want to talk about with the diaphragm specifically is, again, one of the things that we do at Cedars and other neuromuscular diseases is what's called a diaphragm pacemaker. If you've never heard of this, that's perfectly fine because it doesn't really apply to much to CMT patients. However, I get this question all the time where if the diaphragms aren't working very well, can this diaphragm pacemaker that exists, can we put it in and help our diaphragm move? So the thing that I want to mention is diaphragm pacemakers, which we do at Cedars, is excellent for spinal cord injury. Someone that broke their neck, someone that had a trauma and injured their neck. It's an excellent device for that. For other neuromuscular diseases, such as ALS, which is the other big one, the results are very equivocal. I'm not going to get into the controversy of why it's equivocal, but the results are very equivocal. And it's never been tried in CMT. So my recommendation is if anyone reaches this point and is interested in something like that, you have to talk to someone with a lot of knowledge about diaphragm pacemakers to see if it applies to you. And I was asked to show this device because a lot of people don't know what it is, but it's basically an external device that you wear. We put wires, we go in with 3 little holes in the abdomen, and then we put 2 wires in each diaphragm, and then what we get is a little flash drive that comes out and we tape it to the patient's body right here, and this device is external. It connects through this little flash drive and it helps your diaphragm contract. So that's that, and it's not that important. It doesn't really apply to CMT, but it is something that's out there, and if you Google it, hopefully I helped answer that question in your head. The other big thing with diaphragm weakness is when, aside from breathing, is that it diminishes your ability to cough. If you begin having a difficult time coughing or clearing your secretions, you can get buildup of secretions in your lungs. And when that happens, you're more prone to infection, you're more prone to pneumonia. So we try and come up with devices that help clear the secretions in these patients. Really, there's 2 devices out there. This slide, I just mentioned that there is nothing really, there's no good device to help measure cough. So it's really clinical. When you come to the clinic, we ask, is your cough getting weaker? Or when you get a cold, do you have a harder time clearing your secretions? And if the answer is yes, then we do have 2 devices out there that help the patients clear the secretions. The first is what's called the chest wall high frequency oscillator. And basically it's a vest that you wear and it percusses your chest to help loosen the secretions. This is what it looks like. You wear it for about 10 to 15 minutes a day. It comes in different colors, just like your braces and come in different sizes and shapes. So does this vest device. The second is what's called a cough assist. And what this does is it helps force the secretions out if you completely lose your ability to cough. And this is what they look like. And again, it's a mask that you put on your face for about 2 to 3 minutes. And this is a negative pressure that helps clear the secretions out of your chest. All right. So that's it on diaphragm dysfunction. The other 2 things that are involved in my arena is vocal cord paralysis. Now, this is even rarer than breathing problems in ALS patients. But it does. I'm sorry, in CMT patients, but it does occur in usually in kids more than adults. These are your vocal cords, and again, they're innervated by different nerves, and just like any other nerve that becomes damaged in CMT, these can also become damaged. There's two types of. Let me go back a second. There's two types of paralysis. One is unilateral, one-sided paralysis. The other is bilateral. Both vocal cords are paralyzed. With unilateral, that's usually very asymptomatic. Patients don't even realize it. A lot of us may have it and not even know that it's a problem. It doesn't become a problem unless it's bilateral paralysis. With unilateral paralysis, really, sometimes you cough a little too much or you choke a little too much when you're swallowing. And that's usually not a big deal and no one really recognizes it. With bilateral paralysis is when you can have stridor and you can have more difficulty breathing. And these become much more life-threatening. With unilateral, stridor is a very harsh wheezing type sound every time you take a deep breath in and out. I don't want to come up, I don't want to mimic stridor because it's going to sound foolish, but it's, you'll know, the best thing is when someone has, if you've ever seen or on TV, seen anyone with an allergic reaction to a food, and then they feel their airways closing down, and that sound that they're making, that's what stridor is. Again, there's no intervention really for unilateral paralysis. For bilateral vocal cord paralysis, then you unfortunately have to do a tracheostomy. How do we test for it? It's very easy. It's called we use a laryngoscopy, and it's actually very painless and it's not a problem at all. And we just put a little camera, a very thin tube, very thin plastic tube with a camera on the end through your nose, and we see the vocal cords. We ask you to take a deep breath in and out, and we watch your vocal cords move. And although this looks like it may be painful, it's actually not at all. All right, so those are the two rarer problems with CMT patients. The most common problem, again in my arena, is sleep problems and sleep disorder. There's what's called obstructive sleep apnea. There's also what's called central sleep apnea. Obstructive sleep apnea is when the muscles in the neck collapses on you when you're sleeping. And this causes an obstruction and you can't move air and out. Central sleep apnea is more in the brain, and we'll talk about both of those in a second. Actually, right here. It's more brain receptors, and it's, anyone can have central apneas. You're usually thinner, nothing's closing down your airway. Other sleeping problems, and this was mentioned earlier, restless leg syndrome is common in patients with CMT, also periodic leg movements. Restless leg syndrome, and I believe we talk about that now. So what are the symptoms of sleep apnea? You get poor sleep, you get frequent nighttime awakenings, you get daytime fatigue. A lot of patients will come in complaining that when they wake up in the morning, they have a severe headache. These are all signs of sleep apnea. Snoring may or may not occur. If you have obstructive sleep apnea, snoring is much more common. If you have central sleep apnea, which is the more common form of sleep apnea in neuromuscular patients, snoring does not have to occur at all. A lot of times, the sleeping partner, the bed partner will come in and tell me that, I watch them sleep and I think they're going to pass away in their sleep because they stop breathing. They're breathing normally and then all of a sudden they don't breathe for 5 or 6 or 7 seconds. It's a breathing problem. It's more that they have sleep apnea. Restless leg syndrome is discomfort in your legs, pain in your legs when you sit and you're inactive for a while, and that gets better when you get up and walk around. So when you lay in bed for a while, you start getting severe pain in your leg, you stand up and you walk, it goes away. Periodic leg movements are jerking of your arms and legs when you're sleeping. So a lot of these patients, the husband or wife will come in and just say, you know what, I know that she's mad at me, but she's been hitting me all night, or he's been punching me or kicking me. Well, it's periodic leg movements, not so much anger, unless, you did something. So how do you diagnose sleep apnea? Sleep apnea, the best thing to do is an overnight sleep study. It will diagnose obstructive sleep apnea. It'll diagnose central sleep apnea. It'll also diagnose periodic leg movements. There's home studies that you can do at home, which are not as good for central apneas and for periodic leg movements. And then there's in-lab studies where you go into a lab and spend the night and they have a video camera on you, and these will get diagnosed much better in a lab. But we can also do it at home. One of the questions, and again, this is why I put this into the slide, one of the questions that I get is, if I get diagnosed with CMT, or if I know that I have CMT, do I have to get a baseline sleep study? And the answer is no. You don't need a baseline sleep study. You only need a sleep study if you have any symptoms of sleep apnea like anyone else. The treatment, again, I recommend the newer forms of non-invasive ventilators just because they're much better and much more comfortable for neuromuscular patients. However, again, in the CMT world, in this room, if you have just basic CMT with no breathing problems and you have basic sleep apnea, obstructive sleep apnea, a CPAP is just fine, just like anyone else. But if you have central sleep apnea or anything more complex than that, I don't recommend a CPAP. A CPAP is not good for that kind of treatment. I recommend a BiPAP or a more complex non-invasive ventilator. Also, periodic leg movements are treated very well with CPAPs and BiPAPs. If you treat the sleep apnea, the periodic leg movements get better. Restless leg syndrome is a clinical diagnosis that you make. When the patient complains that the leg pain is severe when they're sitting, and then when they walk around, it goes away. That's restless leg syndrome, basically. And there's a lot of pharmacological agents that we can use to treat this. So I think we're okay with time. So in summary, I want to emphasize that pulmonary complications are not very common in CMT patients. However, if you start having earlier signs of breathing problems, it's good to have a plan. It's good to see a pulmonologist in a center that knows how to deal with neuromuscular patients. I recommend seeing a pulmonologist, as I said, in one of these centers. I always recommend going to a center that deals with CMT. And then finally, I also recommend that if you're going to require equipment, if you're going to require a CPAP or a BiPAP, always get it from a company that specializes in neuromuscular disease, that knows what they're dealing with, because they have little tricks and little tweaks that they can do to make things more comfortable for you. I think that's it. All right, and we'll have questions at the end. Thank you very much.
Thank you so much, Dr. Elsayegh.